having a cluster of cases does not mean a second wave. So if we take an example of our colleagues, our friends in Germany, and sorry if I pronounced this incorrectly, but in Gütersloh, there has been a cluster of cases. That's involved a number of positive individuals. 1/3 of those tested has been positive, 7,000 contacts identified and in quarantine. Schools and the childcare in the area have been closed. But in doing all of that, the German authorities hope to avoid a larger lockdown. So what German authorities are doing is a targeted intensification of testing. They're doing smaller measures aimed at suppressing infection. They're trying to limit that geographically and in terms of its impact, and then wait and see, does that work? And if that works, then keep doing that. And they may have to add more measures. They may be able to take some of those measures away. So I think what we really want to see is that agility, that ability to use data, to use investigation, to use testing, to use physical and social measures in an agile, adapted, in a sensitive, empathic way, where you're doing the absolute minimum you need to do to suppress the infection, or the maximum you need to do with the minimum disruption of society. And I think there are good examples like that. I think our colleagues in Beijing as well are mounting a very large-scale response in Beijing in an attempt to prevent that getting out of hand. And we've seen the same in Korea, we've seen the same in Japan, an approach to rapid detection, description, investigation and suppression of clusters, because that's what you get at the end of your wave. You get a few cases occurring and then a super spreading event or something happening, special risk factor, and then those specific clusters have been associated then with reseeding at community level and then more intense community transmission picking up. There is a sort of sequence of events here. So when you start to see a cluster now in the absence of disease, when you're down to a very low level of disease and you see a cluster, you have to jump on the cluster. You have to take the cluster seriously, because you want to avoid that second peak. You want to avoid going back into community transmission. So using our tools in a more precise and agile way is what we need to do if we want to avoid the blunt instrument of lockdown, which we all need to avoid if we can, because of the deleterious social and economic consequences. But if you have full-blown community transmission and your hospitals are overwhelmed, then you have no option again. So we need to give ourselves options, we need to give ourselves choices, and the only way we give ourselves choice is to react quickly. React quickly to the clusters, investigate, suppress infection, limit the measures, and then avoid going back into the more destructive measures as a last gasp attempt to shut down community transmission.
Many thanks, Dr. Ryan and Dr. Wankirchhoff, for this detailed answer. So we will try now to go to India, where we have Nidhi from India TV. You would need to unmute yourself, Nidhi.
Hi, can you hear me?
Yes, now it's fine.
The number of patients who recovered from coronavirus in India has crossed about 2 lakh now, and the recovery rate in the country stands at 54%. Recently, the recoveries moved past active cases as well. How do you read these recovery numbers in India? What do these tell you?
Maria can give you some specific. I mean, it's always great news when we see people recovering from COVID-19. The recovery numbers tend to lag behind because they're very often not reported officially, and it takes time for us to catch up. What we do see in those numbers is a group of patients who are very lucky in many ways to have got through the disease, some people who've been critically ill, but also people who need continued support, people who need, potentially some who've been critically ill need follow-up. This is, at the critical stage, this disease takes an awful lot out of people. They need follow-up medical care. They may need life support, income support, and certainly the last thing they need is stigma. And we've seen situations where, again, patients finding it hard to reintegrate because of stigmatization. So it's very important that we see the survivors of COVID as people who've been through a lot, people who suffered, and people who deserve the care and acceptance of communities as they return. COVID survivors are a symbol of hope for all our communities, and we hope that in India they will provide that symbol for further efforts to control the disease. We're also obviously seeing some interesting and useful therapies emerging, and trying to ensure that patients who need it get medical oxygen, get access to the drugs and standards of care that they deserve. So yes, it's good to see that. There's nothing particular you can read into recovery rates, but I'll ask Maria to maybe speak about that in terms of epidemiologically what it means.
Thanks, Mike. Yes, so we are seeing a large number of recoveries, and we expect to continue to see that. If we look at the breakdown of severity that many countries are seeing amongst the reported cases, there will be recoveries. But what we're trying to do through our clinical networks and through our collaborations with clinicians and medical professionals all over the world is really to understand what recovery looks like. So even in mild patients, who didn't necessarily require hospitalization for care, they are still seeing some lingering effects. And we're really learning what those lingering effects look like. We're hearing people feeling quite tired for quite some time, still feeling a little bit of out of breath if they need to walk upstairs or walk up hills. And so we need to better understand that so that we know what kind of long-term care are required. Those individuals who have had severe disease, who've been either intubated or on ventilation and required more advanced care, they may have some longer or more severe effects going forward. But again, we're working with the clinicians to find out what does rehabilitation look like amongst those that have recovered. But as Mike has said, the fact that we're seeing so many recoveries is a sign of hope. We want to ensure that anyone who is infected with COVID-19 receives the care that they need to prevent them from advancing to severe disease, but no matter what level of disease they have, to ensure that they're cared for even after they recover and they leave hospital.
Next question comes from National Geographic. We have Gabriela Di Bella with us. Gabriela? Can you unmute yourself, please?
Hi.
Hello?
Hello?
Yes, we can hear you now.
Hi. Can you hear me now?
Yes, now it's fine.
Well, first I'd like to thank you for all your work. And in Brazil, we also are seeing a really big explosion of cases of severe respiratory syndrome. And I would like to know how the WHO organization is looking at this picture, and if you're evaluating these numbers too when you look to the country, and if this is happening too in other countries. And thank you.
Sorry. Yeah, I think I said this before. Our team in our American Regional Office, the Pan American Health Organization, have working very, very closely with authorities in Brazil at both federal and at state level. I think in the last 24 hours we've had, again, over 22,000 cases from Brazil and over 1,230 additional deaths, and covering all of the federal units in Brazil. The highest reporting federal units are still Sao Paulo, Rio de Janeiro, Rio Grande do Norte, Espírito Santo, and Pernambuco. The situation across the country varies, and I think that's an important issue in any large country and federated state. The situation and the epidemic situation in each state is very different, and we've seen flattening of cases in some areas, but continued rising of cases in others. I've spoken previously about the health workers in Brazil who've bravely stood in the front lines. We've seen about 15,000 cases of COVID-19 amongst physicians, about 12% of the total in healthcare workers, about nearly 19,000 cases amongst nurses, and also amongst other technicians who work in the hospital space, I think over 40,000 infections. Healthcare workers represent over 12% of the cases, of all COVID cases in Brazil. So these are a very brave, courageous group of people who've stood on the front line and served the people of Brazil with great courage and professionalism over the last number of weeks. The intensive care capacity around the country continues to cope. I said previously that some intensive care units in some areas have come under pressure, but the system continues overall to be coping. But it's difficult for any system to sustain this persistent increase in cases, the persistent pressure on the system. And as I've said previously, this requires an all-of-government, all-of-society approach with federal and state-based systems working seamlessly together in the service of the citizens of Brazil. We will continue to work and support the government of Brazil, the states and the citizens in any way we can to both suppress the infection and save lives.
I just want to add in general what we're doing to support as it relates to dealing with patients and in clinical care in all countries. And we work through our regional offices and our country offices to ensure that not only do we provide guidance in terms of what do medical professionals need to do, how can they best care for patients, which we of course learn through our collaborations internationally. We provide trainings. Whether these are through our Open WHO platform or virtual trainings where we try to have these one-on-one discussions with healthcare facilities and with healthcare professionals. We provide support in looking at surge capacity. What does the workforce need to look like? What do the number of beds need to look like? And in what type of area within the hospital, whether for mild patients or for more severe patients. Ensuring that the clinical pathway is appropriate, whatever that medical facility looks like. Making sure that there's infection prevention and control measures within the health facility, whether that's a community care center or whether that's a tertiary hospital or whether that's a purpose-built severe acute respiratory infection treatment center, to ensure that healthcare workers are protected, that they have appropriate PPE. We're also working to ensure that there's adequate oxygen supply in country so that patients that need respiratory support and need oxygen will have access to that within the country and within the healthcare facilities that are there. But the support is through our regional offices, it's through our country offices, it's through our partners with our EMTs, and it's based on need and it's based on risk. And that is something that we, as WHO, with our partners, are working to provide all countries everywhere based on what they need and when they need it and how it needs to be implemented.
Thank you. Next question comes from Italy. Mariella Bussolati from Business Insider Italy. Mariella?
Can you hear me?
Yes, now we can.
Okay, thank you. I just would like to know the technical details on the measure you are adopting inside the refugee camps to stop or, keep the COVID lower. Thank you.
Thank you. There are the most important measure that we demand, that we request actually to governments is to ensure that whatever measures are taken for the national population include also refugees. So, and this is where we work very closely with WHO because WHO has access to ministries of health, and this is where our partnership is particularly valuable. Now, many governments, most governments have done this already, as I said earlier. But many governments require additional assistance, in particular when population are additional to their national population. And this is where we have mobilized again with WHO's support and assistance, medical supplies, PPEs, whatever is needed to help governments set up those responses. In particular, where there are large refugee camps and you do have to set up, say, for example, quarantine or isolation facilities in a refugee camp. Clearly, we have then worked specifically with governments to do that in those situations. We have worked very much in other areas as well, especially, again, when there are large refugee concentrations. For example, in improving water supplies, which are so crucial, in improving sanitation systems to ensure that there is better hygiene. Often these are very overcrowded situations. We have worked, extremely important as well, on another track, again with WHO, public information. I think we have all learned, all of us, including people like me who are not experts like those people with whom I'm sharing this table, we have all been listening every day to the advice provided by the health authorities or by WHO on how to try to prevent the spread of the pandemic. Washing hands, keeping social distancing, not congregating in large clusters, referring to doctors when we have symptoms, etc., etc. So all of this was necessary also for refugee communities, often in different languages because they don't speak the language of the national population, of the nationals. So this is another areas in which we have been working very hard. So these are really the main areas in which we have been cooperating with WHO, but very importantly with governments that are hosting those populations.
And may I supplement, Philippe, again, with huge thanks to HCR, to colleagues in UNICEF, Red Cross and local NGOs. If we use just a particular example where we've all had concerns and worked together very effectively, we have the Rohingya refugee situation in Bangladesh with approaching 1 million people there over a long period of time. First of all, with great thanks to the government of Bangladesh. Again, the host government is a hugely important factor in the success in caring for refugees. And we've worked very closely with the Institute of Epidemiology and Disease Control to establish laboratories in Cox's Bazar, not just for the refugee population, but to support the local population as well. And very often supporting the host population is very important, as well as supporting the population who's been hosted as refugees. Since the start of April, we've supported over 11,000 tests been conducted in the camps. That's a daily sampling rate of about 500 samples per day. I know it doesn't sound like much, but doing that in a camp situation has its own challenges. We've supported 1,080 bed capacity in 12 isolation centres for severe acute respiratory illness, so that people who do fall sick can, as Philippe said, be treated safely and not infect other patients. And they've been run by partners in the camps. And part of this process is transferring knowledge to local actors, local Bangladeshi and actors, to Rohingya themselves, who have, many of them have professional backgrounds. We've established a referral pathway so we can identify and pick patients out who have respiratory illness, and we've trained more than 200 staff in the camps on clinical management. In addition, we've trained over 800 staff in infection prevention and control, not just in the camp facilities, but in the surrounding facilities within the host community. So working across the health sector, indeed we've also had to update the operational plans for the cyclone season, because if people have to shelter, they may have to shelter in conditions in which they can't physically distance or are much more crowded together. So we've had to update those guidance according to that. So, but doing that while also protecting the immunisation programme, continuing to do routine immunisation and all of the other health services that are needed. So providing healthcare to refugee populations is pretty much the same as providing it to any population, but you're very often doing it in extreme environments, in situations of overcrowding, where resources are limited, where you have a host government that's supportive and providing and facilitating that process. It makes it a lot easier, where you have partners as wonderful as UNHCR then, and the leadership that they show, then the job is much more straightforward. So we very much appreciate, and we would like to achieve that kind of action in every refugee camp, in every country. Sadly, that is not the case yet, but that is the standard to which we wish to aspire.
We will go now to Sarah Jerving from DEVEX. Sarah? Hello, can you unmute yourself? please.
Yep. Sorry about that. Thanks for taking my question. Because vaccine development is at an accelerated, unprecedented rate, are there any concerns that long-term health impacts of a vaccine might not be detected? Are there any concerns about safety when the development process is at an accelerated pace?
I think when we talk about accelerated vaccine development, what we hope is that we're talking about more efficient, faster, but still extremely safe, well-planned, well-managed. So what we're trying to do with many partners around the world, and there are many initiatives which are trying to accelerate the development of vaccine, but not cutting any steps, no shortcuts. No issues that can be shortcut in this, but there are things that have been done to speed up the process of that development, and it's been unprecedented, the cooperation, the collaboration, since many months ago, since the Director General hosted the meeting here of the research and development experts from all over the world in February, and subsequently in April brought partners together here to initiate the Access for COVID Tools initiative. Both have driven that process. But there are no shortcuts in science, and safety is a must. The trials that are underway now are safety trials and efficacy trials will begin. Those first efficacy trials will need to be large, or as large as possible, for two reasons. One, so we can get an early signal of clinical efficacy, but also because if we move from vaccinating small numbers of people to vaccinating very large numbers of people too quickly, we may see effects that would not be detected in a small group. Rare side effects can be detected only when you have a large group of people tested. So we would like, and that's why we've been working with partners all around the world to ensure that the clinical trials that we carried out together are done on as large a scale as possible in order to be able to detect any rarer symptoms or side effects that may come from the vaccine. And it's an important question, and something that needs to be closely monitored. That is often why, even when vaccines are introduced for the first time, they're associated with what they call post-marketing surveillance. There's a much higher need to do surveillance when you introduce a new vaccine, even when it's approved, because there's always a chance of a very rare side effect. You need to be able to pick that up and manage it. So yes, there will have to be great care taken, and we have to balance the benefit of a vaccine that can save lives, and we have to manage the risks that are associated. Immunisation has proven over the last 50 to 70 years to be the single most effective health intervention and the single most effective life-saving intervention for children all over the world. And we hope, as we go through this process, that we will together find a safe, effective and affordable vaccine that will save lives in the coming years.
I would like to add to that. Safety for WHO is very central. And if you remember when we had the publication on hydroxychloroquine some weeks ago and the safety problems that was reported then, we temporarily suspended the Solidarity trial immediately because safety comes first. And with vaccines, the same thing. If a safety issue is raised, then we have to take action immediately. But before then, whatever safety precautions should be taken under the trial or the studies with regard to safety should be considered properly. That's one. And then the ACT accelerator that Mike said that was launched in April 24 was one, to accelerate the development, and second, to ensure equitable access to the vaccine, and for those, the vaccine to really reach everywhere, and those especially who needs it. So you have both components. But although it's not impossible to find a vaccine, it's very important to understand that it's going to be a very difficult journey. And we have to understand that. As you know, there is no known vaccine against any coronavirus so far. So if a vaccine is discovered, this will be the first vaccine for coronavirus. So you can imagine how difficult it could be when you are searching for something first. And the second issue with the vaccine is as we said earlier, the safety issue, which you said, and the safety issue should be assured. But more importantly, once you have the product, it should be accessible. I mean, those who need it should have it. But then, because of the issues that I raised, since this is going to be the first time and all the things I said, our focus should be in doing the basics. The basics meaning the comprehensive public health approach. Something that's already at hand. I have already outlined some of the things before, and my colleagues have already said about them. The testing, the tracing, and the rest, and also what individuals can do. The keeping your distance, using masks when appropriate, and also cleaning your hands regularly, and all the precautions that you can take. We can actually keep away this virus by doing the basics, by understanding that this is everybody's business, and each and every individual should take care of herself and himself and his loved ones. He should care about the others too. When we do that, we can really suppress this virus. And that's why we're daily talking about that. We have to take more on what is at hand. We have to use what's at hand. Thank you.
Next question comes from Reuters. We have Stephanie Nebehay.
Thank you. Sorry. Yeah, I think a question for Mike. We'd be interested in knowing, please, your reaction to comments by China overnight or early this morning about their preliminary findings that the Beijing outbreak is linked to what they're describing as a European strain of the virus. And they've also said that the Chinese authorities have provided data to WHO. Could you comment and also confirm? Thank you.
Yeah, thank you. I haven't seen the sequences myself yet. Maria will maybe speak to that. But when we talk about European strain, we need to be careful. There are different strains circulating. But to be frank, strains and viruses have moved around the world. For example, if you go to New York, many of the viruses that circulated in New York were of European origin. Even in places like Japan has re-imported cases from Europe. So I think it's not indicating that Europe is the origin of the disease at all. What it's saying most likely is that the disease was probably imported from outside Beijing at some point. Establishing when that happened and how long the chain of transmission is important, and that's why we're pleased to see the intensity of the investigation ongoing. To ensure that we can find where that cluster began. And again, it demonstrates just how dangerous a cluster can be in a closed environment. Whether that transmission is occurring person to person or through environmental contamination where an individual can contaminate the environment, and all of the various hypotheses that have been looked at. What is, I think, reassuring is given that this coronavirus looks very much like it's of human origin, and as such pushes very much back against one of the hypotheses that was being pursued by Chinese authorities, that this could have been a breach of the species barrier again, and I don't think the evidence quite points to that. But again, I haven't seen the sequences. I haven't spoken yet to some of our scientific colleagues who may have views on that. But my sense is that we're dealing with the human origin for the outbreak. Exactly when that virus arrived potentially back in China, I think it remains to be determined. What is important is that the cluster was established, and secondly, that there was an amplification again in a closed environment. We need to look in that environment. What are the risk factors that drive transmission in an environment like that? We're in an environment in Beijing where many workers and people working there, and from a cultural perspective, are wearing masks, but they're involved in a lot of activity. They're involved there's a lot of water, there's a lot of air conditioning, there's a lot of freezing. So the environment itself may have facilitated the spread of disease, at least initially. And we've seen that in meatpacking plants, we've seen that all over the world. So what is it about this environment that allows the disease to amplify in that setting? We've seen the same in religious settings, we've seen the same in others. So it's really important to look at what are the factors that drive transmission in an environment like that. And I think currently that's what we're very interested in. We are relieved in the sense that it looks like this is a human-to-human event, but again, we need to understand the details of how that transmission occurred in that particular environment. Maria?
Yeah, just to briefly add that the several sequences from Beijing have recently been uploaded to GISAID, and so these are accessible to be able to look. And as we understand, the virus is closely related to the European strain, as Mike has said. But that was published on the 18th in GISAID. We also, of course, received notification through our country office, through IHR, which we do for all events in all countries. We've had briefings with our country office, and we did have some members from China CDC brief our STAG the other day. But again, this is not unusual. We have a lot of briefings in this pandemic, and just take an opportunity to thank so many countries. We had a briefing from Gibraltar today, for the STAG. We're learning about how countries are dealing with their individual situations, and every opportunity we have through these briefings is to learn. And as Mike has said, some of these amplification events are very important when outbreak investigations can be done, or more detailed epidemiologic investigations can be done, so we could better understand how this virus transmits between people in an attempt to prevent it from happening again.
Many thanks. I will just call now on Mr. Jok, who is joining us from Ethiopia. He wanted to intervene after the question was asked to High Commissioner for Refugees, and maybe Mr. Jok, you could add something on what has been said on that question about COVID in refugee camps.
Thank you. Thank you. Do you hear me now?
Yes.
Yes, thank you. I just want to subsidize what is already answered by UNHCR Commissioner. Just to share the experience, what we are doing in Gambela in relation to how we can prevent outbreak in refugee camp. Currently in Gambela, we have a comprehensive plan, EPRP plan for both, host community and refugee. And we have all the coordination platform that is inclusive for both refugee and host community. And we have only one treatment center now in Gambela that is ready to receive cases for both host community and refugee. And as we said, we are now preparing for the worst case scenario in refugee camp in case are increasing refugee camp. We are preparing now just to treat just mild cases in refugee camp in case are increasing refugee camp. And as we said, most of the partners now are engaging in IPC watch and risk communication and community engagement in refugee camp, just to prevent this one. Beside the strengthening of surveillance to really detect the cases. This is what I want to subsidize, that's to share what we are doing. As UNHCR said, when the government is committed to include this one, I think the communication, I mean the spirit of the virus in the camp can almost be limited as what we are doing in the host community. Thank you.
Thank you very much, Mr. Jok, and good luck with your work. We will conclude this press conference here. I will let Mr. Grandi and Dr. Tedros maybe to say goodbye as well. From my side, just to let you know that audio file will be sent to you shortly, and the transcript will be available tomorrow, and wish everyone a very nice evening. Dr. Tedros, Mr. Grandi, maybe?
Just to once again thank WHO for hosting me here today. Tomorrow is World Refugee Day, so please spare a thought about people that have now one more reason to worry about in their lives, just like we all have, but in addition to that, there are people on the move, people in exile separated from their countries and their families. So I really appreciate this attention on this particular vulnerable group. If I may also at one point, Mike earlier made a very important point. He stressed that whatever we do in refugee camps, in refugee situation, is also directed at communities hosting refugees. This is extremely important. We can't create differentials or different situations, because another risk that a pandemic, as we all know, might generate is further stigmatization of people that are not mainstream in that community. So I think it's very important that we also pay attention to that particular effect of the pandemic. Thank you very much.
Yeah, thank you, Filippo. Thank you for joining us. And tomorrow is a refugee day, and I hope it will be a time to also reflect on how we can support our brothers and sisters who are living in such a difficult situation. And with that, thank you for joining, and bon weekend. See you on Monday during our regular presser. Thank you. And thank you also for joining us, Mr. Jok, and our greetings to our colleagues there. Thank you. And Iman, of course. Shukran.